I would like to welcome all of you to Billing Testing and Revenue Recovery, and thank you for joining us today. In today's presentation, we will take a quick look at billing implementation and testing from some different perspectives. I will first take a quick look at the hospital information system and project plans. We will spend most of our time discussing the laboratory information systems and the billing build, review, and testing. Financial success is the accuracy of billing for services rendered. Therefore, it is critical that charges are billed accurately and on time. This quote about financial success is an excellent quote. We all understand it and know how important billing is. Because billing is a responsibility shared across many areas, and in some cases systems, it can tend to drop through the cracks, especially if the implementation of the system or systems is having some difficulties. Let's review some of the areas of revenue loss. First, poor EHR or electronic health record implementation. Insufficient training of staff can lead to spotty or incorrect documentation of services and charges. Insufficient staff and time to perform all required tasks can lead to errors in database build that can eventually lead to lost revenue. Inflexibility in timeline schedule can lead to a rush build and implementation. In these cases, billing is often left until after go live, as the facility concentrates on areas of patient care. Not incorporating facilities' processes, workflows, and structures into the new system. There is no system that will work 100% for your facility out of the box. New processes and workflows may have to be instituted. Working with staff to ensure functionality of the new processes and workflows is critical. Staff required to work with less than optimal workflows and processes can lead to errors, which leads to the next point. Reduced or no reimbursement due to errors. Not maintaining or providing documentation to support the level of service billed. Workarounds in a system can lead to added staff time and potential for error. Many facilities experience revenue loss after going live with their EHR systems, and this can be attributed to the inability to accurately charge for services provided. Not making changes in charge capture coding and billing processes needed to be compliant with Medicare reporting requirements. Inaccurately using CPT, current procedural terminology, or HCPCS, Healthcare Common Procedure Coding System codes, as well as inaccurately reporting units of service performed can lead to payments being denied. Some other areas of revenue loss. Not testing billing codes before go live. Testing of codes can be done two ways. The HIS Hospital Information System to LIS Laboratory Information System to HIS Billing. This is the most complete, but it does take time. Although it takes time, this is a good way to ensure that billing codes are working. LIS to HIS takes less time, it's not as complete, but it's better than no testing at all. Charges filing incorrectly. A facility assumed that the billing codes they were sending were filing correctly in the HIS billing system. When they later tested the billing codes, it was found that several codes were not filing correctly, and this had been the case for 2 to 3 years. These tests were highly utilized tests, and the revenue loss over that period of time was significant. The code may match if you only compare the charge masters, and the charge still will not file due to some other error, such as an incorrect department code. Incorrect quantity charges and incorrect credits. Ensure that credits that are filed automatically file correctly in the HIS billing. Ensure that credits that are filed manually file correctly in HIS billing. And ensure that items with a quantity charge correctly. Possible fines from federal state regulatory agencies. CMS requires providers to bill accurately using the appropriate CPT HCPCS codes and to report units of service performed. In addition, CMS requires that providers maintain documentation to support the level of service billed. Ensure that all systems capture all appropriate documentation, and ensure that the EHR documents all testing accurately in the patient record. Moving on to HIS-LIS billing database build, there are common considerations for all of these systems. Software can be implemented in several ways. Install the new software and build a database from the standard site image that is included, or If part of a network of facilities, a working copy from another facility in the system may be used. New database builds require review, changes, and updating of information, since the software comes with a standard site image already loaded. Depending on the image used, information can be old. Identify facility processes and workflows and adapt the software as much as possible. Copying databases saves time. It can be beneficial if there's insufficient staff to perform a new database build. But remember that methodologies may not match between facilities. Identify each facility's workflows and determine best practices. Each facility needs its own billing codes. They have their own unique items and may have different departments or focus. Either way, standardization of processes and streamlined workflows can be built into the system. Let's take a quick look at the hospital information system and some things to look for and review. One of the pitfalls of moving to a paperless system is the gaps that are created when something's not documented correctly or not documented at all. These gaps may be responsible for huge financial losses and perceived negligence. In terms of EHR documentation, if it's not recorded, it didn't happen. Round-trip testing for lab results can be performed. Round-trip entails HIS orders to LIS back to the HIS patient chart. Ensure that lab results are filing correctly to the chart. Don't assume the results are filing correctly. They may not file at all or may file but overwrite incorrectly. Some tests are expected to be resulted incrementally. An example would be cultures in microbiology or blood bank products in blood banks. When a preliminary result is received in the HIS, it files over the existing result until a final result is sent. There have been some cases where the HIS does not correctly recognize the information being sent, and this resulted in the final results for different blood products filing over each other. In this case, if the patient received 32 different blood products, the blood bank records reflected 32 products transfused. However, the EHR patient record recorded 1 blood product transfused. So it's important to review these types of tests to ensure they're filing correctly. Specific protocols need to be in place for adding or canceling orders and tests so that the billing or credit generated is accurate and traceable. Billing interface testing for charges and credits should be performed at both the EHR and laboratory origin level. Don't assume that everything's working correctly. Doctors cloning orders. Using cut and paste on patient charts is on the radar of the OIG, Office of the Inspector General. OIG feels that this feature enables providers to inflate their charges by copying documentation from previous notes into current notes. Over-documentation, as described in their report, refers to the practice of inserting false or irrelevant documentation to create the appearance of support for billing higher-level services. Continuing on with pitfalls, not identifying and correcting coding errors can significantly affect your income. To make sure you're on the right track, conduct a sample chart audit and report the findings to all physicians and staff. You might be surprised how simple awareness and focused education can impact the bottom line. The legacy billing system may have a myriad of instances of installed customized programs. Many facilities experience personnel changes, and over time, changes to the system may not have been documented to the complete understanding of the IT department. It's difficult to identify all the nuances within a billing system without testing everything. Many months may be required to iron out the kinks in a new billing system process, and payers may not accept late charges. Because the CDM is an automated process that results in billing numerous services for high volumes of patients, often without human intervention, there is a high risk that a single coding or mapping error could spawn error after error before it's identified and corrected. The entire CDM should be reviewed periodically, but at a minimum, it should be reviewed annually to coincide with annual codes, updates, and organizational changes. Installation of a new EHR can impact the lab in a number of ways. One of the best ways for the lab to ensure that no loss of revenue occurs is to come up with a project plan. When developing an EHR project plan, coordination with other departments is required. Some other things to consider: identify the departments and personnel. How many interfaces are involved? How are the interfaces interconnected? Are there error reports for each interface? Who's responsible for reviewing the interface error reports? Are there billing reports available for each software system? Is the correct CPT code billing code being utilized? Verify against the hospital CDM. Look at facilities processes. Find the places where charges most often slip through the cracks. How often is the lab charge master reviewed? And how extensive is the review? At the LIS level again, the first thing to look at, is this a new database build or a working copy from another facility in the system? Each will have their own issues. A new database build, most software comes with a standard dictionary already loaded. It requires review and updating of information already in place. And depending on the image used, information can be old. Review the CPT and ISBT 128 product codes. Do not assume the vendor has loaded the latest version of these codes. Copying databases within the network. The LIS is already shared within a network, so it saves time. And there's less staff required to perform database build and updates. Methodologies may not match, so review and update is needed. Each facility needs its own unique items, tests, and codes. Review and build as necessary for the site. Do not assume that since this is a copy of an existing working database that things are working. For example, while performing billing testing at Facility B, it was discovered that credits were not filing correctly. The database in use was a copy of the database from Facility A. Upon review of Facility A's process, it was found that credits were not filing correctly in the HIS billing. The credits were being manually filed in the LIS, but not filing in HIS. Facility A had not applied credits for over a year. After this was identified, corrections were made to the databases at both facilities, and confirmation was made that all credits are now filing correctly. LIS system structure and things to look for. Review and update database tables as needed. Identify all the billing tables in the system. Where can you add charge codes in the system? Do you want them to automatically trigger or manually trigger? Identify and ensure interfaces between LIS and all other ancillary systems are functional. Create a flowchart of interfaces with billing and charges as the focus. Ensure mapping of lab tests through the interfaces. Confirm that the test code ordered by the provider in the HIS is mapped to the code the lab is using and resulting and billing. Determine the capabilities of the system. Can it handle multiple tests, modifiers, credits, manual credits, and manual charges? Implementation and training of end users are another common place to find billing errors. All users should understand the importance to patient safety when they order the correct test on the correct patient at the correct time. But do they relate to the financial responsibilities of the hospital? There are always billing procedures that the system just can't handle the way we want them to be handled. So we create a manual billing procedure. These procedures need to be clearly defined, and the responsibility of these procedures must be established. A current and accurate charge master is vital to any healthcare provider seeking proper reimbursement and a key indicator in a healthy revenue cycle. One way to ensure a current and accurate charge master is having compliance and change programs in place. Implementation of a compliance change program will help to keep the billing system updated and working as expected. It will also help prevent things from slipping through the cracks. And having a procedure in place when new testing is added will ensure that each test is tested in conjunction with the HIS patient record and the HIS billing system. Other pieces to consider when instituting a compliance change program. Facility charge master. Each facility has at least one charge master or CDM. If there are departmental charge masters in existence, then it's important to keep them in sync with the facility CDM. CPT codes are updated every October, which makes it important to review and update the CDM on a regular basis. Department-specific staff need to be involved in the review of the CDM to confirm the CPT codes that are mapped are the correct ones. Review of charge descriptions, CPT and HCPCS codes, revenue codes, charge dollar amount, department code, charge status, and facility billing codes need to be performed on a regular basis and updated when required. An example for the laboratory is a test for creatinine. It could be a serum creatinine, a urine creatinine, or a 24-hour creatinine clearance test. If the HIS system is configured by personnel who are not familiar with the clinical lab, The charge descriptor and code may not match correctly, resulting in errors incurred by charging the wrong lab test. The laboratory may have its own charge master. This will need to be reviewed and updated. Again, review the same items just mentioned above. If you have lab-specific items to review, make sure those are noted in the program. And don't forget to compare it against the facility CDM. A compliance program will ensure that all of the above mentioned items are performed and documented. This way, corrective action is taken up front and not when an audit is occurring. Some of the pitfalls to watch out for: not reviewing billing codes, CPT codes, and ISBT 128 product codes in the current system. Not comparing lab charge masters to the facility charge master. It's recommended to review the charge master every 3 years, if not more. For example, a facility has been using the same billing code for a lab test for several years, only to find out upon testing this particular billing code number had been inactivated by the finance department a year ago. Perform round-trip testing between LIS and HIS billing. Ensure that all charges are filing and posting correctly in the HIS billing system. Another pitfall: error tracking mechanisms not monitored. Rushed system implementation could result in multiple charges not filing at a facility due to incorrect codes being sent to the HIS billing. For example, multiple charge codes were not filing at a facility due to incorrect location codes being sent to the HIS billing. These incorrect codes caused charges to file in other random departments instead of the lab, as the new HIS billing tried to match the incorrect code. Some codes that could not be matched in the HIS billing were failed and dropped to an error log. The same scenario happened at another facility, with provider codes being the problem. Each of the interfaces involved should have an error tracking mechanism. The errors found on these reports can be anything from mismatched ADT information to a test code that was not recognized. Many errors are quickly scanned over and dismissed or fixed, but when it involves test code that did not cross, there could be a multitude of problems. If, for example, the wrong test code was ordered in the hospital information system or a test ordered in the lab system was not mapped in HIS, it could lead to no billing generated as well as no results to the patient chart, which relates back to if it's not recorded, it didn't happen. Create a change management process specific to billing charges. Creating such a program specific to billing changes can effectively address the above issues. Perform a random chart review in conjunction with the billing department and report the findings to all departments involved. This will take coordination, but can be an effective tool. Again, when looking at the billing build, is this a new database build or a copy of another facility in the system? The same things that apply for the LIS build apply for billing as well. New database build requires identifying all billing systems for tables for the system. These tables may be vastly different than the tables of the current system, and in some cases, billing may no longer be a laboratory function. It may require a complete new build of all tables, and at minimum, it requires review and updating of information already in place. Copying databases. Methodologies may not match. Each facility needs its own unique billing codes. Updates of tables will need to be made. Automatic and manual billing triggers need to be reviewed. These may vary between facilities. With a shared database, the manual triggers for one site may be viewable by all sites. If the codes are not uniform for all sites, train the staff and have procedures in place. Processes for creating billing reports or processing charges may vary between facilities. Again, training and SOPs are critical. Knowledge of the system structure. Automatic and manual triggers, are they possible? Where and how are they built? What are the capabilities of the system to handle multiple tests, modifiers, automatic credits, manual credits, and manual charges? And put procedures in place for these functions. Verify CPT and HCPCS codes if applicable. Some systems don't have CPT and HCPCS codes in the LIS billing tables, only in the HIS. Verify internal billing codes if applicable. Identify and review all billing tables for the system, and verify billing report and charge processes. A billing compliance program of some type can prevent loss of revenue. The lab has the ability to review the pieces it has responsibility for outside of the hospital review process. The lab charge master update and review. The charge master and billing tables should be reviewed on a regular basis. Again, CPT codes are updated every October and need to be reviewed by staff trained in billing compliance. Review charge descriptions, CPT and HCPCS codes, revenue codes, charge dollar amount, department and internal billing codes, and any appropriate lab-specific information. At this level, a yearly review would be best. Lab test changes. Ensure new testing has correct billing information in all the necessary billing tables, and ensure information is correctly transmitted and applied in the HIS billing. If you build an entry into a billing table for the test but forget to enter the information into a table that links test to charge, no billing occurs. If a round trip really isn't possible, a second set of eyes to review the table build is critical. Along with a billing compliance program of some type, a lab change management program will help prevent revenue from slipping through the cracks. Lab change management protocols specific to billing should be in place and followed. Laboratories need to work with hospital financial staff to reconcile any changes made to the hospital charge masters and to verify that adjustments to laboratory billing tables are made accordingly. All charges to charge masters and billing tables should be tested using the appropriate interfaces. Results of testing should be clearly documented. If the facility is unable to test, an audit of pertinent patient charts and billing records will confirm accurate billing is occurring. If your facility has not done so, an initial audit and complete unit testing of billing interfaces should be performed. A full audit and repeat unit testing should be done periodically, at least every 3 to 5 years. Let's look at testing. Monitoring of clinical laboratory billing is an ongoing process and requires continuous evaluation. Most importantly, each facility should have a billing compliance change management plan in place that is followed. Laboratory management should ensure that qualified resources are available to implement and maintain their written compliance change management plan. When should a facility test? When any new computer system is implemented. This can be the lab, blood bank, microsystem, a financial billing system, or an EHR. For computer system upgrades, a plan for regression testing should be in place. When any new tests or procedures are put into use, when new hospitals or outreach facilities are added to the health system network, when new reference laboratories are being used, when new regulations requiring code changes occur, and upon implementation of ICD-10 codes. Even if the healthcare system shares the same lab blood bank microcomputer database, each facility should test separately. What should a facility test? Automatic billing charges. Automatic billing, charges and credits. Manual billing, charges and credits. Billing report, charge processes from LIS to HIS billing. Charges and credits to ensure they are filing correctly in HIS billing. Multiple tests, modifiers, multiple blood components, and situational testing as indicated by the facility. This could include charges and credits filed after a patient discharge, irradiated units depending on your blood bank policy. An example of this was found at a facility that does not irradiate blood products. A credit for the blood component piece of an irradiated unit that was issued and returned was processed correctly, but the irradiation fee for the unit was not credited. It filed and charged to the patient inappropriately. Some of the pitfalls to look for in billing: inappropriate mapping of billing codes causes loss of revenue, there's a risk of fraudulent charges, and increased audit time. System-triggered charges and credits not working correctly, or the manual charges and credits not working correctly. Modifier codes not correctly implemented in the system. Charges and credits not posting to the correct patient visit. An example would be charges and credits filed after the patient discharge not posting correctly to the patient visit. This occurred at a facility because the charges and credits could not be matched up to the correct visit between the LIS and HIS billing system. They had been dropping to an error log that no one was reviewing. The most important things to remember for billing: do not assume. Test the system, and make sure the billing is working to maximize your revenue. That concludes the webinar for today. Again, I'd like to thank you for joining. Rob?
Thank you very much, Kelly. Just a few reminders before we end today's webinar. All of the questions that were submitted will be compiled along with the answers and sent out to all attendees along with the slides from the presentation by the end of the week. If you'd like to speak to somebody before that, please email me at the address on the screen or give us a call here at 480-346-7011. Again, 480-346-7011. Again, thank you for attending today's webinar, and I hope that you all have a great afternoon. Take care.